All right, perfect. Well, we will get started with tonight's session. I'm Matthew Goodwin from Washington University in St. Louis. I'm going to do something a little bit different tonight. We're going to talk about really the things we think about here as we treat spinal tumors. And so I know most of our talks are really based around the technical side of things and uh, the dare I say the fun side, but the things that we're used to dealing with in terms of the reconstruction, the surgery, that sort of thing. It's going to be a little bit of a step back from that tonight. And I'm going to piggyback a little bit on my talk from several months ago talking about lesions. And we're going to talk about how we think about spinal tumors here at WashU, both from workup to follow through. And so I just had this conversation yesterday with a patient who I saw in clinic 2 weeks ago. And she's in her 70s. She's had a knee replacement, and she had an MRI with lesions and got sent to me because of these lesions. And so we sent her through a workup, and the biopsy looks like it's a plasma cell neoplasm, probably multiple myeloma. And I spent a lot of time on the phone answering questions, and those questions are things that many of you answer, but certainly we answer every day in clinic, and they're about the lesion and where did it come from and what does this mean and what do we do next. And you know, she had questions that had me going back to things I talked about in my talk on lesions, which, things like why wasn't I sent to the oncologist after the MRI was done? And I was explaining that, well, a lesion can be lots of different things, right? And so we went back to talking about how when you first get a lesion on the spine, we don't know necessarily what it is, even if we have some ideas. It could be an infection, could be a tumor, could be something that's benign or malignant. I think I even brought up a recent case where I said, just a few weeks ago, we had a case, 71-year-old female, marrow changes. We sent her to get a biopsy and a workup. And in that few weeks, it actually came back as infection. And in fact, during that time, her spine actually collapsed. And so in that case, that patient, we then took to the operating room and debrided the infection, and she did fantastic after that. But it's very different than if it were to come back as a tumor. And then from there, it's very different depending on the type of tumor. And so this is the type of thing we go through, obviously, every time we're in clinic with patients. And so we oftentimes end up talking about lesions and talking about how we use the term to just mean an abnormal area. Often we mean abnormal area on the scan, honestly, because it might be a normal variant, but it's an abnormal area on the scan. And oftentimes I end up saying to them, look, you have a thing, and that thing could be something that looks like a tumor, could be something that looks like an infection. If it's a tumor, it could be, that patients always want to know if it's cancerous or not. And oftentimes I have to explain that, sometimes things that aren't necessarily cancerous per se might be locally aggressive, right? It might be uh, just as bad or worse than some of the other things. And so, here's a case that you see here of a patient who uh, uh, had a rare disease and ended up doing very well. It was from one of my colleagues at the pediatric hospital that I helped him with. But I'm going to talk about it in a little bit here, but it was an example of a case that I didn't know much about. And so that's also possible that you have a diagnosis that I go, I don't think I've treated that before. And then I have to rely on my colleagues to catch me up to speed, and I have to read a little bit and learn, particularly if it's something I don't know a whole lot about. So these patients get down this pathway after they see me, typically, if it's a lesion, and they're getting a workup. And I think one of the things that we try to keep in mind here when we're dealing with these patients is that this is really stressful for them, even though it's what we do every day. And so they're getting, new scans done, they're getting new imaging, and sometimes, that patients have trouble with that. And so, the patient has a new lesion. Now they've learned it might be cancerous. They're getting lots of tests done. Um, I just added this morning because some may be denied by insurance. This was a note I left in the chart this morning because I had a peer-to-peer and they denied staging studies on a patient with a lesion. So insurance comes into play, and that can be stressful. And the patients oftentimes get told different things, right? So they might get told different things by different providers that that mean well, but maybe aren't as familiar with tumors in the spine, in addition to the things that they may look up and read other places. And so I think it's important to recognize these patients are in a tough place. I try to tell all of them that, hey, look, it's normal if you feel like things are all over the place right now, like almost like you don't have a leader of the team because we're trying to figure it out. And I tell them that's all normal, and to try to let us worry about that and worry about getting them through that process. My dad died when I was an intern, and he had pancreatic cancer. And I wrote a thing about him in JAMA there. And I bring it up because I remember distinctly when he was first diagnosed that he was trying to figure out, you know, did he even want to undergo treatment? Did he want to undergo chemotherapy? What would that entail? Because he was, he had a lot of questions, right? He had stage 4 pancreatic cancer when he was diagnosed, not inoperable. And so, but in the process of him having those questions and being newly diagnosed in the hospital and being sick, people would come by and say, "Okay, we're sounds like we're going to put the port in tonight." And he'd never heard of a port. He didn't know what a port was. And so he'd go, "What are you talking about?" And they'd say, "The port. It's on the schedule. You're getting a port." And he'd go, "I've never heard of a port. I don't even know if I want treatment." And they'd go, "Oh, okay, sorry." And then it would be a shift change, and the next person would come on and say, "So we're getting the port in the morning." And so it became a big joke that he was getting the port, whether he wanted treatment or not. And but luckily he was able to make a joke about it. But for a lot of patients, that's tough when there's so many different voices and so many different things going on, and they're just trying to get a diagnosis. I think it's even harder with spinal tumors because we're a smaller field than a lot of things like pancreatic cancer, for example. And I think the not only is the diagnosis difficult, the treatment's difficult. So it's always confusing for patients initially, I would say, the diagnosis part of it. And it's oftentimes difficult dealing with what the treatment's going to be as well. And so, those 3 cases I just mentioned to start, right? Each one of them, as I'm talking to them, the question is this cancer? Is this cancer? Is this cancer? And you have to go through the whole talk again and explain to them what different things mean and what's, whether it's unstable, whether it's cancer, whether it's infection. And so there's a lot to it, and it's a tough time for them. It's also hard because treatments are not well understood by many people. And so and sometimes we don't even agree on the treatment for these, right? And so I saved this because this was one of my favorite things in the medical chart was when someone wrote unclear why ortho would offer surgery, and this was in a patient with a SINS of 16, so very unstable spine, and I believe had deficits. But other services are not always going to understand indications, and that can make it hard too, right? Because they might have told the patient, no, you're not going to get surgery, and then we come along and say, boy, you should think about surgery for this. And so that can make it confusing. Certainly at our place, and I know several of your places as well, if you're a referral center, you're going to get patients from other hospitals, from other providers. This was a patient who had a primary tumor, we thought, resected, and was free of disease and was following up because he was frustrated with his follow-up and wasn't sure if he was fusing or not fusing, or could he go back to lifting weights. He was a young guy. And so we try our best to not only be upfront and educate these patients, but also not to be too much of the Monday morning quarterback talking about things we would have done differently or not done. And we'll talk about his case a little more a little later. And we have patients that have primary tumors. And so here's a case that I'm just showing you one view on the CT, but you can see if you can see the soft tissue here coming out around the verts. This was a chordoma at C4 that went out around both verts and presented some very unique challenges in terms of talking about treatment options with this patient. So I think, when we talk about spine tumors, I do these with my partner, Dr. Molina, who I think is in the OR now. He might jump on if he gets out. And, we do all our primary tumors together, and I'm going to kind of walk through some of the ways we do it from clinic to the OR and how we make it work. And it seems like it's been a really good system so far. We'll kind of go through some of that. We obviously treat primary and metastatic tumors of the spine. Those are obviously very different, but can be really, really life-changing in lots of cases, right? And so on the left, you see a patient with metastatic disease who comes in and her legs are out, her spine's dislocated, and we take her and we realign the spine and use a little cement, and we actually got her back up walking, and she was alive for a long time after that. Actually, very, very grateful. Uh, and we also do we do the primary cases where you're taking out part of the pelvis. I think we've presented a case like this before here. Or when we have upper cervical lesions that are primary tumors, obviously these can be much more difficult to deal with, and you can get much more complex in terms of needing specialty printed implants, or using different creative ways of using bone grafts to recreate the neck. So certainly we do a variety of things here, and there's some nuance to each of these, of course. As I was putting this together, I thought, well, if you're a spine tumor patient, what are the things you're looking for in your center? Where are you looking to get your treatment? And this is the list that I think encompasses a lot of what you're looking for when you're looking for where to go. So you want somewhere that people are honest and have integrity. You certainly want to have them to have expertise and competence in what they're treating. You want them to have a little humility with that expertise, so they're listening, they are paying attention to you, have some empathy, and then of course location, and comfort, right? What are you comfortable with the provider, with the plan, with the staff? Those are all things that are going to come into play as you're searching for where you're going to get treatment. So the first one's honesty or integrity, and I think like many things in life, I've had just fantastic mentors that I've learned from, and I've seen them live this out, which is how it always works, right? And so it starts with my dad, who I mentioned, and I remember from an early age him saying things like, "We don't lie in this house," and we try to do that in our house as well. Of course, that sometimes you can tell when someone's trying not to lie. You ask them, "Son, did you break the lamp?" And the reply is, "The lamp? What lamp?" Not answering the question. So, but nonetheless, the principle is there that we're we kind of believe in this as something to live by, that we don't lie, and that certainly when we're dealing with patients, we're shooting straight, with them, and telling them the truth. This came up when I was a PhD student. I was doing this mathematical modeling and fitting a lot of curves. It was a lot of math, and I had two different legit ways that you could do some of the fits. And I was talking to my mentor about which one, and he said, "Well, that's your job, is to figure out the one that is the best for these type of data and do that." And I said, "Well, you could also," I was like, "That's silly. You could also just pick the one that gives you significance, or see which one." And I remember that was such an appalling thing for him to hear. He said, "Why would we dedicate our life to doing research if we weren't going to try to find the most true answer?" Right? So he wasn't worried about publications. He wasn't worried about moving up the ranks or any of that other stuff. All he cared about was getting the right answer. And it's always stuck with me because it's something I think about with the patient. If they feel more comfortable going somewhere else, or they want to do a different thing, that's all within the realms. We worry about doing kind of, getting to the right answer for the patient, at the end of the day. Other providers that have kind of taught me that over the years, in terms of honesty and shooting straight and all that stuff, and modeled it for me, really, is what I should say. So, you see Kevin Jones there, my mentor at Utah, up in the upper left. Fantastic surgeon, fantastic human. He's one of the first people I was with that I would see him talk to the family after surgery. And I still do it actually like he does, which is after every case, I go find the family and sit down and talk to them in a room, even if it's a microdisc or something simple, just to say it went great, everything's good, here's what we did. And I remember him doing that when there were complications. I remember a case where he injected too much bupivacaine into an 8-month-old at the end of the case, and it was way too much. And as soon as he did it, he said, "What was that? What that was 0.5%, and it was how much that you gave me?" It was not the normal thing that he got handed, unfortunately. And he recognized it, and they went into the protocol. There were some abnormalities in the vitals, but the anesthesia team was great, and they were communicating, and the patient was stabilized. and was totally fine. It was a non-event essentially, but nonetheless, I still remember, it was a terrifying thing as a trainee and leaving the room and finding the family with him. And I remember him just telling him, "Hey, look, I made a mistake. I did this injection. It was way too much." And it was just so just to the point. I think the kid's going to be fine. I'd like him to be in the ICU to watch him, but I don't think it's going to have any consequences. But early in your training, hear someone say, "Look, I made a mistake. Here's what I did. Here's what I think about it." Patients understand that. It's amazing how the families, they don't expect you to be perfect. They expect you to be near perfect, but they know you're not perfect. But they do expect you to shoot straight with them, and that's always been a valuable lesson. And that's something I've seen with these, other providers I have on this slide here. And so that's Melina and I in the black jackets there, where I have the hood on. He's the exact same way whenever we talk to a patient. Um, one of my most embarrassing times, which ended up being a non-event, was I was using a curette and actually pulling a piece of bone out and slid it across the skin. And I had cut the skin enough that I actually had to sew it up at the end of the case. And it was, almost like I teed our incision. And I remember for me, it was embarrassing to tell the patient, "Hey, look, I kind of slipped across the skin and I had to sew it up." But, I think it's important to shoot straight with patients. And if you've ever been around Mike Kelly, he's just blunt with everybody and he's to the point. And Dan Chu was the same way, which I think is important. And I think it's important when you see second opinions if you're at a tertiary center. So we're certainly the same way here. And I think the caveat I'd say is that that doesn't mean you have to dump on the first surgeon, right? I think that's something we've really worked on, and just as a team in general, that we'd like to get to the point where people feel comfortable calling us and saying, "Hey, I did this. I don't know that it was right. Here's what the path came back as," and that happens. And what we don't want is them to be, not want to call us because we're going to say, "Why'd you do that, you idiot?" Right? And so, these things spine tumors are rare enough that there's going to be plenty of mistakes to go around, particularly as you move further outside a tertiary center. And as you're counseling these patients, I oftentimes end up saying to them, "Hey, I'm glad they got you over here," or "Hey, I'm glad they recognized it when they did." There's always a thing that it's, that's helpful. So here's a case in a guy who was, and that doesn't mean you're not shooting straight, right? I tell them, "Well, this is what I would have done. Here's what we would have done here." And that's all kind of, you kind of have to, I think you kind of have to coach them to say, "Let's look forward about what the next step is. Like, these are all things that have happened. Here's things could have happened, but then none of that matters. Here's how things happen. And now let's move forward." So this guy, 49-year-old, 1 year post-op, like I said, frustrated with his follow-up. When you looked at his op note, he had an en bloc resection for an MPNST. But then when you read the op note, he didn't really have an en bloc, right? He had a piecemeal resection, some soft tissue, some bone, he had a gross total. And interestingly enough, the final path came back as a very rare variant of melanoma. And he went on immunotherapy that was, I guess, incredibly rare, and it disappeared. He has no disease. He also isn't going to fuse, probably because he didn't have any bone in there. And so when I talked to him, I kind of said, "Look, you ended up getting essentially the right surgery for the wrong reason, right? An en bloc would have been for metastatic melanoma that you responded to in immunotherapy would have been the wrong thing." But nonetheless, he wanted to know what could he do with no graft in there. And I said, "Well, I think at some point you'll break your rods, right? And I don't know when that point is. I probably wouldn't do a lot of strenuous stuff in terms of lifting or anything like that." And super nice guy, and he did actually end up having some pain, and he broke his rods. And so at that point, he called me and said, "Something happened. It hurts." We went in. He remained intact throughout this whole time, and we actually did a vascular fibula graft to get him to fuse across the junction. And he's, I think, 3 or 6 months out from that, but it looks like it's already fusing based on the last scan we have. So you got to be honest with them, and then you got to have a little, you got to kind of coach them through where they are, I think. Of course, you need to have expertise and competence. I think most of our talks, because this is a little bit more fun for us, it focuses on what I'm showing you here, the big resections, the fancy reconstructions. I certainly think that's obviously part of it, people that get results in this area. One of the things that comes up when you talk about competence or expertise, and one of the things we get asked sometimes is, "Well, what does that mean? Does that mean I should see an ortho spine person or a neurospine person?" And this is something that comes up from time to time on here in meetings, certainly with patients. I think it comes up less actually as I've moved along in my career because the training is getting more similar. That being said, here the way we do it at WashU is we have a very much a team approach and a co-approach, right? And so all the primary tumors Melina and I do together. And we have a whole team of folks that we're relying on in terms of treatments before, treatments after, diagnosing, embolizing. We've got just a fantastic group here where I don't think there's a lot of ego that gets in the way of us working really well together. And so, for us, I'd say the co-surgery makes it easier, it's safer, it doubles the experience of the hands at the table. It also doubles the colleagues you bring. So our flap team, for example, is is in part of it is our hand team within orthopedics, and so they actually work also with some of our plastic surgeons, and that's kind of our flap team we use. Our chair, Dr. Keefe, is an orthopedic oncologist, so I've asked him about many a case, and we've done lots of cases together with him and with Dr. English, and in terms of the spinal pelvic cases, we know our oncologists very well, and so we're very we communicate a lot about these cases, and almost always have a multidisciplinary approach to treating these patients. So that doesn't answer the question though. What's the difference in the training, ortho and neuro? And this is the typical path. You've seen this before, possibly in some other talks. What is a spine surgeon's path throughout their life? Well, most go to college and then medical school, maybe some grad school in there. And then if you're an ortho surgeon, you do ortho residency for 5 years, and then you do a fellowship for 1 year, and then you're an attending. If you're in neurosurgery, you have a 7-year residency, and you may or may not have a spine fellowship because you've done a lot of spine in your residency, and then you're a spine surgeon after that. And so it used to be, well, ortho, this is kind of the old school thinking, right? Orthopedic surgery has to do with hardware, drills. They're going to place the instrumentation, and neurosurgery is going to do the decompression. They work with the nerves and the spinal cord. And as I think most people listening to this know, that's pretty outdated. There's still some areas, obviously, where it's their area or it's our area, but in reality, a lot of training is becoming spine training now, which is ultimately a good thing. And so what was my path, and how did I end up where I am? Well, so medical school, and then honestly, like many people I found out, my path to orthopedics was because of a mentor. So I was in medical school in New York City, and I met John Healy at Sloan Kettering, and he had a profound impact on my trajectory and on my life. And if you know him, you understand that. He's just one of those people. And he is the reason I went into orthopedics. And in fact, it was even his fellow who said, you need to take a hard look at Utah, when all I was looking at was really kind of east and northeastern schools at that time. And so I ended up going into orthopedics. And it was in my residency where I met Daryl Brodke, who's now the chair at Utah, a spine surgeon, fantastic human. And he said, if you want to do spinal tumors, you need to be with somebody doing spinal tumors. And really, the person doing a lot of spinal tumors is Dan Shuba. He's like, you should be with Dan Shuba for a year and learn everything you can from this guy. And I went home and I said, okay, I looked him up and I came back and I said, Dr. Brodke, he's a neurosurgeon. And Brodke said, yeah, that'll be perfect. That'll be great. That'll be perfect for you. And I said, I don't even think, how does that work? I can't do that. And he said, sure you can. We'll do that. We'll set it up. And so that's what we did. So we did, I then did a neurosurgery fellowship with Shuba at Hopkins. And it was a fantastic year. And that was where I was before here. And so what's the difference? And some of this is based on literature. Some of it's based on experience. There's obviously differences between individual providers, right? Ben Carson, he's a neurosurgeon. He was got into politics. He was a presidential candidate at one point. Mike Lane has achondroplasia, orthopedic surgeon, spine surgeon, right? So there's all sorts of differences between surgeons, right? What we're talking about is differences in the training and what they do to get where they are, right? So if you look at orthopedics and you look at neurosurgery, they're both going to do a lot of cases in their training, right? So they're both going to do 1,500, 2,500 cases, right? Some will do a lot more, some will do a little less, but that's kind of where they're all going to fall out. The difference is in their spine training, right? And so if you look at the average graduate and the number of spine cases that they do, you'll see that neurosurgeons are doing over 400 cases on average, and orthopedic spine surgeons are doing 50, 60, 70 on average. So big difference. And this has been published in a variety of different ways. There's several papers actually looking at this, but they consistently show that the orthopedic resident has less than 150 cases, and generally the neurosurgery resident typically has more than 400 cases. Now, the caveat to that is that there really aren't any ortho folks going through residency and then starting to practice spine, right? They're pretty much going to do a spine fellowship where they're going to do 300 to 400 cases in that year, and thus kind of catch up in terms of experience. Whereas neurosurgery is really ready to go after residency in terms of starting their career. So if you're a graduating ortho resident, you're something like in terms of spine experience, you're something like a neurosurgery PGY 2 or 3. And when I started my fellowship, I recognized that, right? Because I was scrubbing as the fellow across from neurosurgery residents of different levels. And you kind of notice the feel, how people dissect, and you kind of notice where you are in terms of the feel, just the flow, and how many, and even talking to people. I remember talking to folks and asking them, how many C12s have you done? And at first I remember being like, how is it possible you've done that many? I've done one at that point. And but it's just because they have a lot more experience. And so by the time you finish your fellowship, you're going to be, if you're an ortho spine person, much closer. But still there's that difference. Part of that difference, or in fact a big part of that difference, is because of the minimum requirements. And so if you're an orthopedic resident, you're only required to do 15 spine cases. And so that's kind of an interesting thing there. Now most, like you saw earlier, are going to do 50 or 60 or something like that, but still it's not a big part of your training in residency. And that's been shown lots of different, like, again, there's several different papers showing this where they look at this. That's pretty consistent across the literature. And it's pretty consistent that you're going to do a fellowship and you're going to do a lot of cases there. And then you can kind of look at outcomes and say, well, is there a difference doing it those different ways, right? And so people have looked at that. They've looked at surgical outcomes between orthopedic spine providers and neurosurgical spine providers. And at the end of the day, there's not a lot of difference. There's lots of different papers. Some of it depends on who wrote it. Some of it depends on what they looked at. It seems like most of the things are pretty much the same. Some of the things that do look like probably real differences that you can find is that it looks like there's, or at least you could find. I think this is probably changing too. That in neurosurgery, there was typically less bleeding, less blood transfusions, less bleeding. And that was certainly something I recognized right away, is that when I came to Hopkins, there was, Shuba didn't want any bleeding in his cases, and he would stop any bleeding. And I don't know if that's a difference from, training and working in the brain versus training and doing hips, where you're kind of bleeding the whole time and you got to move forward and put a rod in. And so that was certainly, and you're used to the bleeding in that case, but that was certainly something I noticed as well. Nonetheless, the point is that, when you look at the training, the difference is neurosurgeons spend a lot more time in spine than orthopedic surgeons do. But again, this changes once the orthopedic spine surgeon then goes through their fellowship. Question is, though, is there a better model? Is there a better way to do this, particularly in orthopedics, where you spend a lot of time doing other things before you do a lot of spine? And you could say, well, why not just let the neurosurgeons do all the spine? Well, that's actually one approach. There's some problems with that. One would be orthopedic departments like having a spine division. Another one would be that not all trainees know they want to do spine until they have an exposure to it. And so I was certainly in that group. I was going to do orthopedic oncology until I was exposed to it and realized I wanted to do spine. There's also a numbers game, right? So there's a lot more ortho residents that graduate per year than there are neurosurgery residents that graduate. And so there's a lot more numbers in terms of availability to treat folks that need treatment with their spine pathology. I think there's an advantage of having two attendings, one from ortho or one from neurosurgery in these cases. I think you bring different backgrounds, different skills, you have different colleagues. I think there's a real advantage now, having done this a lot, to having both of that in the room during these complex cases. And again, I think you also increase patient access. And so the way we have it worked out here is that if a patient has a lesion and they're coming in to see one of us, the primary tumors are going to be done by both of us anyway. And so they can kind of get in with whoever they're going to see, whether it's Dr. Molina or myself, wherever we can fit them in opening wise to get them seen and get them moving along the path of getting taken care of. That's what we try to do. What's that going to be for the future? Is it going to be combined residency? I don't think that's likely to be it. There's a lot of hurdles to having something like that. And I don't think it's necessarily better, even though that's been a thing that was floated for a while. I think, kind of what's happening now is you're seeing more of these combined fellowships. You're seeing, more exposure to each specialty in different fellowships, right? Whether it's officially combined or not. And so also, here at our place in our fellowship, we have, in our ortho fellowship, we have fought hard to keep Dr. Molina in our rotation because we think it's that important to have neurosurgery as part of their what trainees go through when they train with us. And still we have neurosurgeons that actually come train with us as well for a year. And so I think that's likely to be more of the future as we train spine surgeons, right? That there's more kind of cross-pollination. There's groups like AO Spine that are doing things that are spine things, right? So there's the Global Spine Diploma Program. There's a Global Spine exam. I was a oral examiner during that, and it's interesting, right? Because as you get to examine everyone, ortho, neuro, under the same umbrella, you start seeing things like, when there's a Scully case, neurosurgeons sometimes have a lot more trouble. When there's an intradural tumor, the ortho surgeons have a lot more trouble in terms of just working through the case. And so it's interesting that we're, I think, all becoming better because of what we're doing now. So again, it's a team approach. For us, we really do all work together. We have a spine tumor board every week. We keep it virtual right now. It's a Zoom. And that's because our numbers are much better virtually than they ever were in person. And that's because people can get on it, right? We have a big medical center here, and we have people spread out all over the place. That's the nature of medicine now. And we can have everybody there, and even our oncologists will sometimes get on, which is tremendous, which is great. And so that's been really fantastic. Like I said, each referral typically goes to one of us. If it's a primary tumor, that's going to be worked on by both of us either way. Sometimes it's a case like this intradural lipoma at the bottom here that comes into my clinic because I had an opening that morning, but it's not something I would typically do on my own, right? This would be a Molina case. I might help them with it, but certainly, such an impressive intradural pathology, I would want them to talk to him about many of the nuances, even if I feel pretty good about a lot of it. But that's fine. So I see him, and then I told Molina about it when I saw him later, and then he's going to see him as well. But I guess our idea here is, or our thought is that we want to get the ball rolling, right? A lot of these patients can't wait, don't want to wait. You want to get them in, you want to get them seen, you want to kind of give them some information, relieve some of their fears and get them onto whether it's a biopsy or whatever the next thing is they need to get done, and not have them waiting around. Because we do such a team thing and such teamwork, we do a lot of kind of weekend Zooms or late night Zooms. Sometimes if we need to get on the same page about a surgery that's coming up. In terms of the surgeries themselves and rounding afterwards, we've really kind of done that in a way that makes sense. And so usually if it's a complex patient, we both end up rounding, Molina and I both are rounding on them anyway, in addition to our teams, right? But we kind of make it make sense. So these patients are taken care of. Excuse me. And then follow up, we oftentimes we'll tell them, hey, look, let's work out a follow-up schedule that makes sense. If you're here on a Tuesday, because that's when you're going to see the oncologist, or when you're going to see whoever, you can probably come over to my clinic and we can get the film we need, because these patients already have so many visits that you try to ease their burden a little bit and work with them. All right, honesty, expertise. Okay, we'll move a little faster through the last couple ones here. So, the next thing I think is you probably want your provider to have a little humility. I think that's something we try to do. And so when they don't know what something is, they say, boy, I don't know a lot about this. I will find out and we'll take good care of you. And so this was like I said at the beginning, a case of L5 collapse. And it was Rosai Dorfman, a histiocytic disease in a 12-year-old. And I helped our ped surgeon with this. And when I first saw the diagnosis, I said, well, I need to read a little more and I need to talk to the pediatric docs that deal with this disease because I don't know much about it, and I don't think I've treated one before. And so this patient did fantastic, is probably too fantastic because she wants to cheer and do all sorts of other stuff, and I'm trying to slow her down. But certainly helps to be humble when you get these rare things because we see a lot of rare stuff. This was a girl who we published. She was the seventh ever patient to have fibrocartilaginous mesenchyma on the spine. And so we published this report, and it was kind of fun. I gave her the paper when she was in clinic, which she appreciated. But she wrote this really nice letter to the hospital and to me about how grateful she was for the care that she got here. And it keeps you humble, right? She put in here, I just noticed this, that she said she remembers her first visit. It lasted nearly an hour, and she remembers me turning my phone off when it started to ring and letting her know she had my complete attention. And it's funny because I read that now and I go, gosh, I don't remember that. I certainly don't remember that at all. I do believe my visit lasted a long time because they still last a long time. Um, but I don't remember the phone stuff. And in fact, as I read this, I was embarrassed because I remember being in a patient's room earlier this week and the phone, buzzing with text, I think, from the resident about something. So I do think patients notice that stuff. I do think we try to be cognizant of it. We try to be humble about these rare diseases, and we try to, this kind of brings up the last point I have here, which is we try to pay attention. We try to listen. We try to have some empathy. I think that paying attention is post-op as well when we see them and listening to their complaints or looking for any problems that they might be telling us about. This patient I showed you earlier with the infection, just a fantastic woman, and she came back at her 6th week and had a foot drop, and she'd never had a foot drop. And in fact, at the time of her diagnosis, the infection, she had some phlegmon in her lumbar spine, just a little epidural stuff lower down, very small, asymptomatic. And she'd been on antibiotics. Her labs had been trending down. She'd been intact. And then she came in with about a week of a foot drop. And so I said, well, you have a new chain. And she was not worried about it. She didn't have any of the spinal cord stuff she had before. She said, yeah, now my foot's acting funny. And I said, well, you have this stuff lower down. We should probably, you have a new deficit and it's going to, her daughter said she'd been tripping on it for a week. And I said, we should admit you, get new scans and figure out what to do. And so we did. Phlegma looked the same. I don't know why it started to cause a foot drop, but we took her and just did a simple decompression that next morning, and her foot drop got better, and there was scar all over the root. And so I'm not sure what took her over the edge, but I certainly think it's important to pay attention when things like this happen, when there's a new neurologic thing. In fact, the resident is the one that saw him first and said, and she has a foot drop. And I said, she's never had that. So I do think that's important. And she was been great since then, walking around normal. So, especially I think paying attention is important when there's a complication. This is something I say all the time that I learned from Dan Shuba. He would always say in my year with him that when there's any complication, that patient's your best friend. And he would always kind of do that, like you put in their, he'd like make the thing like put your arm around. He's like, that's the patient. You're finding out what they need. You're finding out what service needs to see them. You're finding out. You're doing whatever you can to help them because part of what you did took them into that complication, right? And so it was always a humbling thing, especially with these big cases. But I think the point is well taken, and that is that if you're going to do these big things and take care of these complex patients, part of what the patient needs from you, and part of what we try to provide is that you're going to take them through it. You're going to even the bad and the good parts. You're going to take them through it, right? And you're going to help them get through it, and that's kind of the point. People used to also ask Shuba in clinic, well, what would you do if it were you? And he would always say, well, you don't want to know what I would do if it were me. He'd say I'm a, whatever he was at the time, 40-something-year-old neurosurgeon. My answer is probably totally different than what would be best for you. And and he would, so 67-year-old with a cervical chordoma encasing the verts. He'd kind of say like, well, the question is, what's the best thing for you when we consider the options, when we consider the outcomes, when we consider the risks. And I think that's an important thing to have to work through with patients. We were recently, Dr. Molina and I were both at a conference at MD Anderson on spinal pelvic tumors, and it was fantastic. And Dr. Healy spoke at the end, and they were talking about risks of these big surgeries. And somebody was saying, well, you can't cover all the risks because there's not enough time. Visits would be too long. And his comment was, when you're in the room, your job is to show that patient that you care. And it was such a simple thing, but it was pretty profound, right? And he kind of said, well, it doesn't matter how you do it. Maybe you do it by spending a lot of time with them. Maybe you do it by making eye contact. Maybe you do it because you treated them with respect and answer questions. But maybe you had a short visit, but they got the message. And he's like, your job is to get the message across that you care. And you're never gonna tell them all. You're never gonna explain to them all the things that could happen in this massive thing you're about to do, even though you're gonna try. But you got to show them that you care about what you're about to do, and you're going to help them through it. I thought that was a remarkable thing, because it seems to be true. He's had we don't have time to go through him here, but he's had so many great pearls. I've learned so much from this guy in treating complex patients. One thing that always stuck with me is that he would talk about clinic visits, and he would always be dressed nice. He would talk about shining his shoes. And he would say, this is one of their most important days in this patient's life. They might have come from wherever to be there. And he said, we're gonna treat it that way. We're gonna treat them with respect. We're gonna treat the visit with respect. And he would sit down and listen, and he would answer every question, and to the best of his ability, and convey the message. In addition to that he cared about what was going to happen, right? And I think that's it was such a great lesson to learn. He also would I think he also embraced trainees with fire in their belly. That was something he'd written on one of my evals. But I remember not understanding, I think, the hierarchy at some point in my life. I got into a few arguments or discussions with him about, I don't even remember now, but something that had to do with some of my doctoral work, and he was so refreshing to discuss stuff with, and you could tell he really enjoyed people that had, as he said in the letter, the fire in their belly for some of this stuff. Well, since I've showed the case, I'll show you here. This is the patient with the chordoma, without being too technical here, as we're running short on time. She had tumor around both her verts. You can see here, actually, it's around her right one, and it's kind of almost circumferentially on that left one. It was hard to tell if it was or not. Not a perfect surgical candidate. She had diabetes, already had some baseline issues with breathing. This thing spanned from C3 to C5. BMI 40. So we're already kind of pushing the limits of something that would get it on block. And so, we talked at length with her about kind of what the options were and what we could do. And at the end of the day, we said, we'll start posterior and decompress. We'll expose one of the verts. And, if it's not encased in tumor, then we'll try to separate it. But if it is encased on the side that looked better, then we'll proceed with an aggressive, en bloc-ish is what we say, surgery. So we're not going to piecemeal it out, but we're still treated like an en bloc, knowing that we're going to have some residual on the vert if that's the case. And sure enough, that left side actually had some residual even in the canal on that side. We had little nodules in there that were in discontinuity. And so we sent those for frozen, which we don't do very often. And they said, it looks like tumor. And so we proceeded with knowing with isolating the verts, skeletonizing the roots, but knowing we were leaving some tumor on those verts when we took it out. So we went in the back first and did that, C2 to T2. And skeletonized everything, put in a big bone graft, which you can see there in the back, and then came back in the front, removed C3 to 5 en bloc, and then actually put a piece of femur there. You can probably see here we've notched the C2 in the front, and we've notched C6 at the bottom, and then used this piece of a femur as a strut to support her from 2 to 6. And we just have a little a maxillofacial plate holding that notch in. That notch is actually malleted into the bone on either side, though. So it's a press fit essentially, and this is really just to keep it from coming out of where it's press fit in. And she did great ultimately, but she had a long hospital stay. The surgery was hard on her. She had a prolonged intubation. She had a prolonged extubation with high flow oxygen. She had a C5 palsy that was mild and recovered relatively quickly, but certainly had that, which we talked about before because we were going to skeletonize those roots. She had dysphagia for weeks that got better, and she had some vocal cord paralysis, and that also ultimately recovered. So I think this is why it's important when you tell these patients, say, we're going to be there for you. That's because they're going to go through a lot, and they have to know that, and they have to have some comfort knowing that you're going to be there as they go through that. So I think the last thing that we'll end with here is that there's got to be some comfort level, I think, both with you as the provider, with your team, with the location. I think we are fortunate that we're in a city with a huge medical center, which means we have kind of access to everything and numerous experts, but it's still pretty easy to get around, still pretty cheap to come stay, and there's a little bit of Midwest hospitality, which is nice. But nonetheless, they got to be comfortable with the location, with the team, with all those things. And so that includes the city, that includes the staff. It's important that they have family that can help. They might have family in a different city that might be better for them to go there. I like to tell patients I'm always happy for them to get a second or third opinion. I think that's healthy. I think it's not healthy if it delays care, and I'll tell them that if I think it's going to delay care and it's going to be a problem. But in general, if they can get another opinion, I think that's great. I mean, that's typically what we're doing anyway, right? We're doing this multi-D stuff, getting other opinions for that same reason. So I actually think all that's great, actually. So to end, this is kind of the I guess our thought process of how we go about treating spinal tumors here, and what we've done, Dr. Blaine and myself, as we've kind of built up the spine tumor center here. Is we've tried to kind of think about what it is that you need or what it is you want if you're a patient with a spinal tumor. We've tried to provide that, and I think we've been honestly very fortunate just with our location and our colleagues and the access to things we have to be able to provide a lot of that. So with that, I think we will end. Thank you for your time. I am happy to take any questions if there are questions. There is a chat here. I did not see that earlier. I apologize. Says in poor surgical candidates, what non-surgical adjuncts do you most commonly employ at Washington Barnes, and how do they compare to the surgical options? That's a great question. I think this is referring to poor surgical candidates that have primary tumors, I'm guessing. How do they compare? Yeah, I think that's what that means. If they're not going to be able to get a surgery, what can you? Yes, I think that's a great question, and I think I think there's a variety of things, right? And so I think it depends on what it is and depends on what the problem is. Certainly for a poor surgical candidate who has some issue with or questionable issue of instability, we're oftentimes thinking about talking to MSKR about cement or something like that. Now that's nuanced, obviously, right? Because it depends on what the lesion is, what else they can do to it, whether it's a primary or a met, and whether, how unstable they are, right? Putting some cement in bone is not going to help a lot of instability depending on what it is. But in where there's compromised bone, maybe it's borderline and it's a patient who can't get a surgery, it can be very useful. And I can tell you our MSK IR folks here, Jack Jennings and his group, are very sophisticated and I'd say cutting edge in what they treat in terms of doing things like cryoablation and the other different things they do to either ablate or treat things locally before putting the cement in sometimes, or sometimes separately. So that's useful. In a case where it's a primary, it changes a little bit, right? If it's a chordoma, one of the things that we'll talk about, for example, in that patient with the chordoma around bilateral verts, one of the things we're going to consider is, well, if we can't get an en bloc, what does it look like if we do just radiation, just like protons, for example, heavy ion radiation of this. And there's some data on treating people that now the older they get, the better that might be, right? Because you're probably not really curing it, but you might be kind of controlling it, I guess, so to speak. Um, and so she was right at that age that it's tough, right? 67 is um, right in that area of debating that or discussing that as a valid treatment. In her case, she wanted to proceed with the surgery. I think she needed a surgery either way, actually, because of instability issues and where the thing had gone through the pedicles and the bone had cracked. But that's certainly something we think about with the chordomas. Um, but we're always discussing it. Another question was, what's the principles in your center for secondary tumors metastasizing to the spine? Um, I'm not sure I know the question exactly, but I will say, in general, the when there's the reasons we end up operating for metastatic disease on the spine would be uh, number one, instability, and number two, compression on the spinal cord or nerve roots. Those would be kind of the two big areas that would, you know, uh, two big surgical indications. The instability component, I think SINS is a great classification uh, for this, which I know we talked about a lot of sessions. The 6 different categories to help determine if something's going to be stable or unstable. And that's one of the few, we just were looking at this in a paper we're writing. That's one of the few things that, one of the few scales that has come out that has caught on, people know about, and people use. And it appears to be valid, right? And so the complaint is that there's a big middle ground, a big gray area. Well, that's like any scale. It's very useful, I think, in particularly trainees. It was made for other non-spine surgeons to evaluate whether they needed to see a spine surgeon, right? So it's useful for that. And it's a common language that we can all use as we discuss the stability. Well, I want to thank everyone for being on here. This is obviously one of my favorite topics, and I'm always humbled by the outstanding colleagues I get to work with here and the fantastic things they do. And I'm looking forward to our next session. So, with that, I think we will jump off and see you next week. Thanks for joining, everyone.